Good afternoon, everyone. So I will be speaking on Teclistamab, a dosing schedule which is not FDA approved basically, but it's somewhat routinely used nowadays. It's called as the fast but not so furious. It's a condensed step-up dosing schedule of Teclistamab, which is a bispecific antibody used for treatment of relapsed refractory multiple myeloma. So begin with relapsed refractory patients of multiple myeloma have a very poor prognosis. If the patient is triple class refractory or penta refractory, their PFS and overall survival is very dismal. Teclistamab, it was the first BCMA directed bispecific antibody to get approved as per the Majestic trial in 2000, October 2022. So the results of Majestic trial showed these patients were heavily pre-treated. Basically, majority of the patients were penta-class refractory or triple-class refractory. So even in this heavily pre-treated patient, the overall response rate of teclistamab was 63%, and in this, 39% of the patients they have achieved complete remission or better than a CR. The PFS was 11.3 months, and the overall survival was 18.3 months. But the most common side effect observed with teclistamab was CRS. It was almost seen in 72% of the patients. But the grading of CRS was mild. It was only grade 1 to grade 2 CRS occupied majority of the cases. And the severe CRS, it was seen in less than 0.6%. Neurotoxicity, basically ICANS was seen in 14.5% of the patients, but grade 3 or above ICANS was seen in 0%. So the teclistamab, it's not directly given in a first treatment dose. It is given in a step-up dosing schedule. The FDA-approved step-up dosing schedule it is given on day one, that is 0.06 mg per kg on day one. Then you have to observe the patient at least for 48 hours for any symptoms of CRS or ICANS. And if the patient doesn't have any symptoms of this, at least for 24 hours prior to the next dosing, then only you are allowed to go to step up dose 2, that is 0.3 mg per kg. So day 1 you give 0.06. If the patient is asymptomatic, you observe the patient 48 hours. The patient needs to be admitted in house for all the step up dosing and also for the first treatment dose. So day 1 0.06 mg, patient is asymptomatic for 48 hours, you go to 0.3 mg per kg on day 4. Again, observe the patient for CRS or ICANS. If the patient is asymptomatic, then on day 7 you give the first treatment dose of 1.5 mg per kg. And if the patient is asymptomatic for 24 hours or 48 hours, you can discharge the patient, and subsequent weekly doses would be continued on outpatient basis. So this study was it was a single center study. It was a retrospective study where they had used an alternate schedule of a condensed step up dosing, where they had used step up dose 1 on day 1, step up dose 2 on day 3, and the first treatment dose on day 5. Why they had used it was to reduce the rate, hospital charges rate, and also the resources. Study design and setting. This was a single center retrospective analysis. It was done between November 2022 to August 2023. It was conducted in the Medical University of South Carolina. Population included adult patients who were relapsed refractory multiple myeloma. Treatment protocol: teclistamab, a bispecific antibody against BCMA. It is given in subcutaneous fashion. Step up dosing 0.06 mg per kg on day 1, a symptomatic patient, then step up dose 2 of 0.3 mg per kg, and the first treatment dose of 1.5 mg per kg on day 7. So FDA approved is the standard protocol on day 1, 4, and 7. That is a 72-hour gap after each dose. And the condensed schedule includes step up dose on day 1, step up dose on day 3, and the first treatment dose on day 5. Technically, only 48-hour gap between each subsequent doses. And for all the doses, the patient needs to be admitted. And prior to each dose, pre-medications are administered. Dexamethasone 20 mg. The mode of administration was per oral in this study. Acetaminophen 650 mg, diphenhydramine 50 mg. Monitoring and discharge, vital signs and CRS symptoms were checked every 4 hourly. To proceed for the next dose, the patient had to be asymptomatic for 24 hours, at least 24 hours. The patient can be discharged after the first full treatment dose if the patient was asymptomatic for 24 hours. And after the initial cycle of day 1, day 3, day 5, or day 1, day 4, day 7, the subsequent cycles were conducted on an outpatient basis. So, what were the endpoint? The primary endpoint was to see the incidence of CRS, severity, and timing to compare whether the standard dosing and condensed dosing had the same incidence of CRS and ICANS. And the CRS and ICANS, they were managed as per the institutional protocols. Dexamethasone or tocilizumab were used as per the grading of CRS. So this study had 25 patients. The median age was 66 years. Majority of the patient was male. Median lines of prior therapy was 5. And out of the 25 patients, 11 patients had received a prior BCMA directed therapy. So this were the two dosing schedules. One was standard and one was the condensed. The condensed was day 1, day 3, day 5. So 18 patients, they had received the condensed step-up dosing. So what were the results? CRS occurred in 13 patients, but the majority of the patients, they had grade 1. Grade 2 CRS was seen only in one patient. What was the fever pattern? Majority of the patients, they mounted a fever after the step up dose 2. If you see, out of the 13 patients who had developed CRS, 11 patients had developed CRS after dose 2, and only one patient had developed CRS after the first treatment dose. So the what was the negative predictive value? Basically, if the patient didn't mount a fever after the 2 step up dosing, you can say that the patient negative predictive value of patient not mounting a fever after the first treatment dose was 0.92. So if a patient is not having fever after the first 2 treatment doses, so you give the treatment dose and you can safely discharge the patient. Basically, if the patient is not having fever after the first 2 treatment doses, first two step up doses. CRS, majority of the patient, they had received dexamethasone for the treatment of CRS. So if the standard schedule was used, the hospital stay, median duration of hospital stay was 9 days. And in the condensed schedule, the hospital stay was of only 6 days. So in India, basically, it doesn't matter. But in US, definitely the pricing is very high. And for condensed schedule, the 70% of the patient were discharged within the 7 days. Despite the 52% of CRS incidents, majority of were of low grade, which were managed with dexamethasone. Some patient requires tocilizumab, but none patient had required an ICU admission. The CRS severity and timing were consistent with the prior trial, so it was seen in the similar fashion between the standard dosing and the condensed dosing. There was no late onset CRS or ICANS in the condensed dosing, and the high negative predictive value of CRS after the first doses supports early discharge consideration. Patient selection and considerations. But this condensed schedule, it should not be used for patients who have a very high disease burden, whose ECOG performance status is not good. For example, if the patient is having bone marrow plasma percentage of more than 50%, so giving a condensed dosing regimen in this patients can be tricky. These patients can mount a severe CRS. So selection strategies should include risk stratification. Patients having very high bone marrow plasma cells should not undergo condensed schedule. Strong follow-up plan post-discharge is needed. And even after discharge, patient should be advocated to monitor for delayed CRS or ICANS. So what was the impact on cost and system of the condensed reduce on the condensed schedule? Hospitalization cost in US, it is basically $2,250 per night. So if you reduce if the hospital stays lessened by 3 days, you save at least $6,750. So the annual projection in 50 patients per year saving, it is estimated to be of 3,37,500 per year saving is there. So if you give condensed schedule, it is cost effective and also reduces health burden. So condensed step-up dosing of teclistamab is safe, effective, and well tolerated. It reduces hospital stay and cost. And this may be applicable in outpatient settings with proper monitoring, and also if you use a prophylactic tocilizumab nowadays before giving teclistamab, it's a practice that we administer tocilizumab. Usually it is given prior to step up dose 2. So if we combine both these approaches, giving prophylactic tocilizumab and giving this condensed regimen, it can work. Thank you.